particular class, we are going to study about the characteristic features of a good physiological and the behavioral diagnostic test. Correct? So, we in audiology, let us say, speech language pathology also we have tests, but we will take for audiology. Diagnostic audiology, second semester class. No? Okay, so what do? We try identifying which tests are considered to be good, both physiological and behavioral. Behavioral means the moment you do a behavior, it may be eye blink, it may be a startle, it may be a finger raise, that's a behavioral test. Physiological test means we do something to which the machine records the response of how the body changes. For example, if you give a click sound and we stick out some electrodes on our head, try picking up the neural responses, that's a physiologic test or an electrophysiologic test, correct? Similarly, autoacoustic emission also does that. Done? So, which test do you call as a good test? So, there are some approximately 12 to 13 characteristic features. So, what is the first feature? The first feature would be the validity. Means the test should be measuring the functions it intends to measure. So, the test should be a valid test. The second property is the reliability. What do you mean by the reliability of a test? The test should be giving the same results even if two different people do it, or if the same person does it 2 times. Now and 15 days after that also. So it should be the same thing. I give an example of what? Let us take example of 2 tests. The first is the pure tone audiometry. So here I am making a person sit down. I am doing pure tone audiometry now. Let us say sometime around 4:30 to 5 p.m. And then tomorrow morning I say come back at 7:30 to 8 a.m. and we will do the same pure tone audiometry. Pure tone audiometry. Normally I do the ABR also now, that is between 4:30 to 5 p.m. and tomorrow morning. Which test do you think would have the same results? Test retest, ABR would be there because it is not influenced by the noise. Evening hours, people are going home, we have so many vehicles parked, they are going, that will be getting influenced by the noise. So the test retest is not good for PTA in this environment, but ABR is not influenced. So that is what is known as the reliability of a test. The third is the sensitivity of a test, which means that every test is made to identify a particular condition. For example, the autoacoustic emission is made to identify the condition of the outer hair cells. The ABR is made to identify the condition of the neural synchrony of the lower brainstem only. So if there is an issue with the outer hair cells, the autoacoustic emission should perfectly say yes, there is a problem. If there is an issue with the acoustic nerve, autoacoustic emission may or may not say. So, if autoacoustic emission identifies the outer hair cells appropriately, it is having good sensitivity. Clear? The third is specificity, which goes along with sensitivity. Specificity means that it should be taking off people who do not have the condition. So, normal should be normal. For example, there are a group of 100 newborn children who are 100 newborns who are born. I have to do a test. I know only 2 or 3 would be having maximum hearing loss. So I go with the autoacoustic emission. It very efficiently, 90-95%, distinguishes what? The normals from the people who will be having any hearing loss because of the condition. Okay? But when I go to the NICU, I want the test to identify the people who are having the problem. So I should be having a test which should be having a good sensitivity. So I go with the ABR because I want to identify hearing loss, correct? So sensitivity is different and specificity is different. The next is age appropriateness. We know that children, newborns will be coming to us, adults will be coming, adolescents will be coming. Depending upon them, we select our test. For example, you will be doing ABR and OE for screening for a newborn. But the moment the child is now 6 months to 8 months old, we start doing the VRA. The moment the child goes into 5-year-old, we start doing the pure tone audiometry. The moment the child is 2.5 years, we start doing the play audiometry. The moment the child is above 10 years, we start doing the speech audiometry as well. So we select based upon the age. So age, the test should be age appropriate also. Objectivity means the test should not be influenced by the tester. Only then it can be having a good Inter-test reliability. If I do it here, I do it in London, it should be the same thing. So the test should be objective in nature. The next is, the test should have standardized procedures, equipments and interpretation. For example, pure tone audiometry. If you miss the instructions and start doing it up and down like that, it will not have the inter-test reliability, it will go off. In pure tone audiometry, you have two findings. One is the pure tone average and other is the slope of the audiogram or the shape of the audiogram. The pure tone average, is there any chance to get a wrong information? PTA 0 means 500, 1K and 2K. PTA 1 means 500, 1K, 2K. PTA 0 means 250, 500 and 1K. PTA 2 means the higher frequencies. Correct? So exact value would be there. But the slope of the audiogram, some 7 types of slopes are there and shape of the audiogram. It is again subjective. So standardized procedures for the test is there, but interpretation is not very defined in terms of the slope of the audiogram. So errors would be there. The next property is the time efficient. It should be quick. It should be very non-invasive and safe as well. Auto-acoustic emission became a landmark in terms of audiology because of auto-acoustic emission, which can be done in 30 to 60 seconds, and it is non-invasive in nature, we could do it for newborns also. And immediately we could identify and screen out babies who are prone to be having hearing loss or not. So, time efficient and non-invasive characteristic feature brought up the auto-acoustic emissions. Then easy to administer. Practical, same auto-acoustic emission. Even nurses can do it. So the total number of people getting caught with hearing impairment increased. Newborn hearing screening, adult screening happened out very well. Acceptability. The procedure should be accepted by everybody. So in the hearing evaluation, otoscopic examination is probably the test for which people will be hesitating. Right? Many of them may hesitate to go inside the audiometric rooms and get the ABR done also. So acceptability is also a matter which needs to be emphasized for a good diagnostic test. Then we have the usefulness, diagnostic usefulness. We have the ASSR also, no, which predicts the degree of hearing loss. Fine. But it is so vague that not much acceptable. Understood? So diagnostic usefulness also should be there. So we'll rely upon the pure tone audiometry more than the ASSR. Although both seem to be giving a good one, and ASSR is much more updated and technical in nature. And the last one is, it should be having a normative value. The normative value should be available for that population. Speech audiometry, for example, if the normative value is not available for that population, it will be useless. Fine. So these are the 13 properties of a good physiological and behavioral diagnostic test. Okay? Thank you. Question number 9.